On behalf of Walter Kluwer, a warm welcome to our speaker and attendees of this anatomy webinar under our Medical Edge series. Our topic today is the pectoral region and mammary gland. Our learning objectives today will be, you will be able to describe attachment, nerve supply and action of the pectoralis major and pectoralis minor muscles. Describe the location, extent, deep relations, structure, age changes, blood supply and lymphatic drainage of the breast, and describe the applied anatomy of the pectoral region and mammary gland. Our speaker today is Dr. Satish Kumar Ravi, who is the MBBS MD Professor of Additional of Anatomy. He is also Editor-in-Chief, National Journal of Clinical Anatomy. He is also an additional proctor and assistant controller of examination. He is ex-sub-dean academic and assistant dean academics. He is right now located at All India Institute of Medical Sciences, Vibhadra, Rishikesh, India. He is also ex-course director and head of department, School of Medicine, St. Lucia, North America. Also, we will be taking all questions at the end of the webinar, and I request you to post all your questions in the Q&A panel of this event. We'll try to address the maximum questions at the end of the session. Also, we'll provide all the recording of the webinar to all the attendees who are going to fill up the feedback form for us. Now we begin our session, and I hand over the session to Dr. Ravi and request him to please start sharing his screen.
So good evening, one and all. First of all, I thanks Mr. Ravi Shukla for inviting me for the another lecture under this Medical Age series. And I'm thankful to the Wolters Kluwer team for organizing these webinars to educate and train the medical students of the country. So it was so exciting and you can say overwhelming to interact with you all in the previous webinar. And I hope that the previous webinar helped you in understanding the concepts of the brachial plexus. And motivated by the previous webinar or the lecture, you can say the way you have shown the interest to learn the anatomy by this medical age series. Today I'm here to discuss another very important topic, and that is the pectoral region and mammary gland. So without delaying much, I'll straightway come to the topic. I will be discussing the various competencies, that is the describe the attachment, nerve supply and action of pectoralis major and the minor muscle. Apart from that, the subclavius, describe the location, extent, deep relations, structure, age changes, blood supply, lymphatic drainage, microanatomy and applied anatomy of breast. Apart from that, we'll discuss the development of breast, and we will also discuss the clavipectoral fascia. Apart from that, the clinical aspect. So we'll start with the case scenario over here. You can see we have taken one case over here, that is a 60-year-old lady presented to the OPD with a painless lump in the upper part of her right breast. Lump was small initially, but later progressed to lemon size over 4 months. On examination, the lump was hard with irregular margin. Breast revealed the pseudo-orange appearance of skin with limited mobility and retraction of the nipple. Axillary lymph nodes were enlarged, and with mammogram and FNSE, she was diagnosed to have breast cancer. Now, to understand from where this lump, the breast lump, is arising, you can say that anatomical basis of the signs observed like pseudo-orange skin or the appearance, you say the fixity of the breast. Apart from that, as I mentioned over here, that is the retracted nipple or the axillary lymph nodes, right? These were the enlarged. So all these will have anatomical basis, and we need to understand the detailed anatomy of the breast so that you can understand the case better, the clinical condition better. So we'll start with the introduction. If you see over here, when we talk about this pectoral region, The literal meaning, or we say that when we discuss this pectoral region, it is the front of the chest, you can say. Right over here in this diagram, you can appreciate over here the anterior region of the chest, and it includes, which anchors the upper limb to the trunk. In this diagram, you can see over here, this is the upper limb, and over here this trunk. So this pectoral region, this links the upper limb with the trunk. And the other important structures which you will find in this pectoral region, or you say the pectoral region contains, these are the a pair of the breast, you can say. Over here you can see in this diagram. Apart from that, it will have the muscles like the pectoralis major, minor. Apart from that, superiorly, just on the inferior surface of this clavicle, you will be getting the subclavius. We have the serratus anterior towards the posterolateral aspect, you can see over here. And then apart from that, we will be we will be discussing in the pectoral region whatever the vessels are there or the axillary lymph nodes are there. We will be discussing one by one. So what I wanted to say over here, that this pectoral region, that says, means when you discuss this pectoral region, it is the anterior region of the chest, or we say the thorax. So over here in this diagram, if you can appreciate over here in the midline, you have this sternum, and this sternum has three parts. Superiorly, you can appreciate over here, this is the mammary sterni. Then the another part is the body of the sternum, and then inferiorly we have the xiphoid process. Apart from that, if you can appreciate, this is the clavicle, right? So both sides you can appreciate this clavicle. This mammary sterni is articulated with the body, you say the body of the sternum, or there is an angle found between this mammary sterni and the body of the sternum. That angle we call it as the sternal angle, and clinically it is very significant because the counting of ribs starts from this sternal angle, because over here you will be getting this second rib, and accordingly you can count the ribs. Apart from that, there were various uh, other structures which you will find at the level of the sternal angle, like when you see this trachea, it bifurcates at this level. Apart from that, when we discuss this ascending aorta anteriorly, it continues as the arch of aorta, and posteriorly this arch of aorta at the same level, it will continue as the descending thoracic aorta. Apart from that, if you can appreciate over here, just in below this clavicle, or we say the infraclavicular fossa, there you will be getting, when you press deeply, you will be able to palpate this coracoid process in the deltopectoral triangle. Now, I said that in the pectoral region, we will be, when you dissect this pectoral region, you remove the skin, you remove the superficial fascia, you remove the deep fascia, you will be getting the following muscles in the pectoral region. The very important, the very first muscle which you will come across in the pectoralis, this pectoral region, is the pectoralis major. When you cut and reflect this pectoralis major, you will be able to appreciate this pectoralis minor. As I said, the subclavius will be present on the inferior surface of this clavicle. Apart from that, you will be getting the serratus anterior muscles. So these muscles you will be appreciating, you will be able to see when you dissect the pectoral region, when you reflect each structures one by one. When you reflect muscles, you will be able to see all these four muscles. So the very first muscle we will discuss about this pectoralis major. So when you see this pectoralis major over here, the pectoralis major muscle, it arises by three heads. One is the clavicular head, another is the sternocostal head, and the third one is the aponeurotic head. So in this diagram over here, you can see this is the clavicle, right? So the area, from the medial half of the clavicle, of the anterior surface of the clavicle, this clavicular head arises. So I said there are three heads of the pectoralis major. One is the clavicular head, which arises from the anterior surface of the clavicle, where from the anterior surface of the clavicle, the medial half of the anterior surface of the clavicle will give origin to the clavicular head of the pectoralis major. Similarly, when you see the another head over here, this is the sternocostal head, you can appreciate. So this sternocostal head, it arises from the lateral part of the anterior surface of the sternum, and it from second to sixth costal cartilages it arises. So one is the clavicular head, another is the sternocostal head. I said this sternocostal head arises from the lateral part of the anterior surface of the sternum from second to sixth costal cartilages. Then the third head I said that we have is the aponeurotic head. This aponeurotic head, it arises from the aponeurosis of the external oblique muscle of the abdomen as well as from the anterior abdominal wall. So these are the three heads of this pectoralis major. When we have discussed about the origin of this pectoralis major. Now, when we see this pectoralis major muscle, it inserts where when we see the humerus has the two lip in the upper part, two lip, that is the lateral lip and the medial lip. So we have this intertubercular sulcus. This intertubercular sulcus will have two lip. One is the lateral lip, another is the medial lip. And between these two lips, we have a floor of the intertubercular sulcus. There on the floor of the intertubercular sulcus, you will be getting this latissimus dorsi. Now here we will concentrate on the pectoralis major. So this pectoralis major, it inserts on the lateral lip of the intertubercular sulcus. Now, when we see about the insertion of this pectoralis major, the insertion of this pectoralis major is very characteristic. Why I'm saying this, that it has bilaminar insertion. Means it forms two lamina. One is the anterior lamina and another is the posterior lamina. So this forms the bilaminar tendon and it inserts on the lateral lip of intertubercular sulcus. Now, when you see this, the bilaminar insertion or the bilaminar tendon, it is approximately 5 centimeter broad, which is inserted on the lateral lip of the intertubercular sulcus, or otherwise it is also called as the bicipital groove, or you say the intertubercular groove of the humerus. So this anterior lamina of the tendon is formed by the clavicular fibers, which you can appreciate over here. These are the clavicular fibers. So I said this anterior lamina is formed by the clavicular fibers, whereas the posterior lamina is formed by the aponeurotic fibers. When we see this sternocostal fibers over here, you can see these are the sternocostal fibers. These sternocostal fibers forms the base of the U-shaped structure, which you can say, which forms the bilaminar tendon or the insertion. So the two lamina are continuous with each other inferiorly, which forms the U-shaped base. The lower sternocostal and the abdominal fibers in their course of insertion, if you can see over here, it gets twisted in such a way that the fibers which are lowest are inserted at the highest, whereas the twisting fibers from these twisting fibers, it forms the rounded axillary fold. So this is all about the insertion of the pectoralis major. When we talk about the nerve supply of the pectoralis major, this pectoralis major is supplied by the two nerves. We say that is the lateral pectoral nerve and the medial pectoral nerve. In the previous class, I have already discussed that this lateral pectoral nerve comes from the lateral cord of the brachial plexus, whereas this medial pectoral nerve comes from the medial cord of the brachial plexus. Now, when we see this pectoralis major muscle over here, this you can appreciate this pectoralis major muscle. We have this clavicular head, we have the sternocostal head, and then we have this aponeurotic fibers. I said this pectoralis major muscle, it gets inserted on the lateral lip of the intertubercular sulcus, which is present on the upper aspect of the or the superior towards the superior end of the humerus. Over here, you can see this is the bicipital groove, this is the lateral lip, and over towards the medial lip, you have the medial lip. So on the lateral lip, you will find the insertion of the pectoralis major muscle, whereas on the medial lip, you will find the insertion of the teres major. And on the floor of the intertubercular sulcus, I said there will be insertion of this latissimus dorsi muscle. So I said that the nerve, this muscle, the pectoralis major, gets innervated by this lateral pectoral nerve and the medial pectoral nerve. The lateral pectoral nerve will have root value, that is C5, C6, C7, whereas the medial pectoral nerve will have root value C8 and T1. Now coming to the actions of this muscle, that is the pectoralis major. Now acting as a whole muscle, if you say, it brings about the adduction and the medial rotation of the humerus, that is the shoulder joint. Whereas when you talk about only this clavicular head, it produces or it helps in the flexor of the shoulder joint. Now, when we talk about this sternocostal head, it helps in the extension to bring the flexed humerus to the side. That basically it helps in the climbing. Apart from that, this muscle, it is also called as, you say, the accessory muscle of the inspiration when humerus is fixed in abduction, you can say. Now, over here, you can see this is the another muscle, we call it as the pectoralis minor. When you see this, when you cut and reflect the pectoralis major muscle, you will be able to appreciate this muscle that is called as the pectoralis minor muscle. Now, as you can see in this diagram over here, this pectoralis minor, it will appear, or it appears as a triangle in shape. So this is a triangular muscle which lies beneath this pectoralis major muscle, and you can say it is a key muscle of this region as axillary artery. If you remember, in the previous class also I discussed that this axillary artery is divided into three parts by this muscle, that is the pectoralis minor. So this pectoralis minor works as a landmark which helps in dividing the different parts of the axillary artery. If you remember, I said this first part of the axillary artery, it extends from the outer border of the first rib to the upper margin of the pectoralis minor. Similarly, I said the second part of the axillary artery, it extends from the outer border of the, or the upper margin of the pectoralis minor to the lower margin of the pectoralis minor. The third part of this axillary artery, it extends from the lower margin of the pectoralis minor to the lower border of teres major. So these are the different parts of the axillary artery. Now, its upper border, if you see over here, just in the first part, as I said, that first part will give one branch, right? And that branch we call it as the superior thoracic artery, or otherwise it is called as the supreme thoracic artery. So superior to this upper border, you will be getting the supreme or the superior thoracic artery. Along this upper margin of the pectoralis minor, I said you will be getting the thoracoacromial artery, whereas along this lower margin of this pectoralis minor, you will be getting another branch of the second part of the axillary artery that we call as the lateral thoracic artery. Now, when you see over here, this lower margin or the lower border of this pectoralis minor muscle, it gives attachment to one of the very important ligament, and that ligament we call it as the suspensory ligament of the axilla. Now, when we talk about this origin of this pectoralis minor, uh, it arises from the upper margin, or you say the outer surfaces of the third, fourth, and fifth ribs, and in between the intervening fascias are there. So it gets its origin from there. I said it arises from the upper margin and the outer surfaces of the third, fourth, and fifth ribs, and apart from that, the intervening fascia. Now, when we talk about this insertion of this pectoralis minor, you can appreciate over here, this is the coracoid process, right? So the coracoid process is one of the process of the scapula. As you might have been discussed, that this scapula has three processes. One is the acromion process. Another is this coracoid process, and the third one, which you will be getting in the dorsal aspect of the scapula, that is the spinous process. So in this diagram, you can appreciate over here, this is the coracoid process. Over here, you can see this is the acromion process. So when we talk about this insertion of this pectoralis minor muscle, it converges upwards laterally to form a flat tendon, and it is inserted on the medial border. If you can appreciate over here, this is the medial border of the coracoid process, and apart from that, on the superior or the upper surface of the coracoid process. So this is the tip of the coracoid process. This will be the lateral border of the coracoid process, and over here you have this medial border of the coracoid process. This is the upper or the superior surface, and inferiorly you have the inferior surface. So what I said, that this pectoralis minor muscle, right, it arises from third, fourth, and fifth ribs, right, and the intervening fascia, and it inserts on the upper surface and the medial border of the coracoid process. Now, when we talk about the innervation or the nerve supply of the pectoralis minor muscle, as we have seen that this pectoralis major muscle, it gets innervation from the lateral pectoral nerve and the medial pectoral nerve. Similarly, the pectoralis minor muscle also gets its innervation from the medial and the lateral pectoral nerves. Now, when we talk about this medial pectoral nerve, what happens that this medial pectoral nerve pierces this muscle, right? And medial pectoral nerve supplies this muscle by piercing the pectoralis minor muscle. So these are the origin and insertion and the nerve supply of this pectoralis minor. Now we will see the action. So when we talk about this action of this pectoralis minor, it stabilizes scapula, because if you see over here, it has its attachment on the coracoid process of the scapula. So it stabilizes this scapula by drawing it forwards around the chest wall, that is the protraction, and it depresses the shoulder along with the you say this levator scapulae and the rhomboides. So these are all the action of the pectoralis minor. Basically, what I said, that it stabilizes this scapula by drawing it forwards along the or you say the around the chest wall. So these are all about the origin pectoralis minor muscle. Now, when we talk about this applied aspect of this pectoralis major, over here you can see the partial or the complete absence of this pectoralis major, that we call it as the Poland anomaly or the syndrome, right? So there may be complete or the partial uh, absence of this pectoralis major muscle, and that I said it is called as the Poland syndrome. So there will be the abnormal pectoralis major muscle that may cause the chest to appear concave, you can say, and in some cases there may be additional muscles on the affected side of torso, and you say the including muscles in the chest wall and shoulder. So what happens that in apart from that, in the Poland syndrome, apart from the partial or the complete absence of the pectoralis major, sometimes what will happen that even the breast may be missing or the underdeveloped, you can say. So there may be chances that rib cage abnormalities might be there, such as you can say the short end of the ribs, and the ribs may be noticeable due to the, you can say, due to less fat, or uh, just when it is present just under the skin, that is we call it as the subcutaneous fat, right? So this is all about the Poland syndrome. Apart from that, if we see that many people, when you see with the Poland syndrome, they have hand abnormalities also on the affected side. So commonly you say because of the underdeveloped hand, or you can say the abnormality that is the short fingers, which is called as the brachydactyly. So what I wanted to say, that the Poland syndrome will have the partial or the complete absence of the pectoralis major. In some condition, there may be the uh, absence of the breast or the underdeveloped breast will be there. In some individual, in case of the Poland syndrome, there will be abnormalities on the affected side, that abnormalities in the hand, I said. And what will happen, that is the brachydactyly, where you will find the short fingers will be there, or you say the underdeveloped or the vestigial fingers will be there. So this is all about this Poland syndrome. Apart from that, the pectoralis major flap, if you see, it has been considered that this pectoralis major flap, it is the workhorse flap for the chest, and you say the sternoclavicular defect reconstruction. So we also use this pectoralis major flap in case of the sternoclavicular defect reconstruction, or you say even for the when we need flap for the chest. So in those conditions, we may use this pectoralis major flap. Now, another muscle, that is the subclavius. When you see over here in this diagram, this is the first rib you can appreciate over here, right? And this is the clavicle. So this subclavius is also another triangular muscle, you can say, which arises from the junction of the first rib and the costal cartilages. So over here you can appreciate in this diagram, this is the costal cartilage, and over here you have the first rib. So this subclavius arises from this costal cartilages and the upper surface of the first rib, and it inserts on the inferior surface of the clavicle. When you see this inferior surface of the clavicle, there on the inferior surface of the clavicle, there is a groove, right? So on the groove of this inferior surface of the clavicle, on the groove of the inferior surface of the clavicle, there will be insertion of the subclavius muscle. So I repeat, sorry. So I was telling that this is a triangular muscle which arises from the junction of the first rib and its costal cartilages. Now, when I said that this subclavius muscle, it gets inserted on the inferior surface of the clavicle. On the inferior surface of the clavicle, there is a groove. That groove is called as the subclavian groove. So on the floor of the subclavian groove, this subclavius muscle gets inserted. Now, when we see this nerve supply, this subclavius muscle get its innervation by the nerve to subclavius. If you remember, we discussed this brachial plexus, and in the brachial plexus, we had this upper trunk of the brachial plexus, and from this upper trunk of the brachial plexus, there were the two nerves which arises. One is the supraclavicular nerves, suprascapular nerves, and then another we have this nerve to subclavius. Both the nerves will have the root value C5 and C6. So what I wanted to say that the subclavius nerve gets a subclavius muscle gets its innervation by nerve to subclavius, which has the root value C5 and C6. Now, when you see over here, if you see this subclavius muscle, it helps in stabilizing this clavicle over here. Now, we will see another muscle, that is the serratus anterior. When we talk about this serratus anterior muscle, this serratus anterior muscle is also called as the box's muscle, right? And it is a broad sheet of muscle which forms the medial wall of the axilla. It arises by the 8 fleshy digitations you can appreciate over here. So it arises by this 8 fleshy digitations from the outer surface of the upper borders of the upper 8 ribs, you can say. And whatever the fascia which are covering this will be giving origin to this serratus anterior muscles. So when we talk about this, first digitation appears in the posterior triangle of the neck, whereas the lower 4 slits interdigitate. If you can see these lower 4 slits, first these are the 8th, 7th, 6th, and the 5th. So these 4 lower slits interdigitate with the costal margins of the external oblique muscle of the abdomen. Now, when we talk about this innervation of this insertion of the serratus anterior muscle, when we see this scapula has 3 borders. The superior border, we have the lateral border, and we have the medial border. Now, when we talk about this medial border, this serratus anterior muscle, it gets inserted on the costal surface towards the medial border of the scapula. Now, I said that it has 8 digitations, right? So when we see over here, this all 8 digitations, it passes backwards around the chest wall, you can say, and reach the costal surface of the medial border of the scapula. When we talk about the first digitation of this serratus anterior, it inserts between the superior angle and the root of the scapula, whereas the second and third digitation of the serratus anterior, it inserts on the medial border extending from the root of the spine to the inferior angle, whereas the rest, the 5 digitations, it inserts on the inferior angle of the scapula. So this is all about the insertion of the serratus anterior. I repeat, I said it has 8 digitations. The first digitation, it inserts on the superior angle to the root of the spine, whereas the second and third digitation, it inserts on the medial border towards the costal surface, extending from the root of the spine to the inferior angle, whereas the rest of the lower 5, you say the digitations, the last 5 digitation, it inserts on the this inferior angle. Now, when we talk about this nerve supply of this muscle gets its innervation from nerve to serratus anterior, or it is also called as this long thoracic nerve, or it is also called as the nerve of Bell. When we talk about the serratus anterior muscle, it arises from the roots. It comes from the roots, and the root value, if you see over here, it will be C5, C6, and C7. So it comes from the roots of the brachial plexus, and it gives innervation to the serratus anterior. Now, when we see this serratus anterior, it helps in the protraction of the scapula. So the lower 4-5 digitations along with the trapezius, you say, it helps in the rotation of the scapula forward and upward, right? So because of that, I said it is also called as the boxer's muscle because it helps in punching, that is the protraction. So the glenoid cavity is turned upward during the elevation of the arm above the head, and that is because of the lower fourth or fifth digitations of the scapula. So I repeat, I said the serratus anterior, it is also known as the boxer's muscle, right? And basically the action of this muscle is the protraction. It helps in the protraction of the scapula. So whenever there is an injury to this, because it supplies, it gets its innervation by the nerve to serratus anterior, whenever there is a injury to this nerve to serratus anterior, it will lead to the clinical condition we call as the winging of the scapula. So in the next, you can see over here, whenever there is an injury to the nerve to serratus anterior muscle will get paralyzed. And when you can see over here, because of that, whenever there will be paralysis of this serratus anterior muscle, the medial border of this scapula, right, will get upwards and it appears like a wing, right? So because of that only, this condition, it is called as the winging of the scapula. So the paralysis of the scapula, whenever there is a paralysis of the serratus anterior, this medial border of the scapula will be will become upward because of the injury to the long thoracic nerve. So in this condition, I said this medial border of the scapula becomes very prominent when the affected person pushes against the resistance, you say. Now coming to the clavipectoral fascia, if you see over here. So when we see this clavipectoral fascia, as the name itself suggests, the clavicle that extends from this clavicle, you can say, right? So it is a strong sheet of fascia deep to the clavicular head of the, you say, the pectoralis major, and it stretches from this pectoralis minor to the clavicle. If you can see over here, right, what happens that when you see this inferior surface of the clavicle, right, on the inferior surface of the clavicle, there is a groove, subclavian groove, and or the margins of the subclavian groove, you will find the attachment of this clavipectoral fascia. Now, what happens that both the margins of the clavipectoral fascia, you will find the attachment of the clavipectoral fascia, the both the slips joins together and becomes one, unite, and then what happens that it it divides into two, right? And when you see this pectoralis minor over muscle over here, right? So it stretches from this pectoralis minor over here, it encloses this pectoralis minor muscle, then again the two slips unite over here. So what I wanted to say that this clavipectoral fascia, it uh, it is a fascia which extends from this inferior surface of the clavicle. It encloses this pectoralis minor, and uh, superiorly it splits to enclose this subclavius, and then below again it splits, it encloses the spectralis minor and merges with the suspensory ligament of the axilla. So when you see this clavipectoral fascia, it is pierced by some of the structures, and these structures are thoracoacromial vessels. We have this lateral pectoral nerve, cephalic vein, and then we have the lymphatics. So these are the structures which pierces this clavipectoral fascia. When you see the extension of this clavipectoral fascia, medially it is attached to the first rib and fascia covering the first two intercostal spaces, you can say. Lateral attachment, when you see of this clavipectoral fascia, it is attached to the coracoid process, and you say it also blends to the ligament, we call it as the uh, costoclavicular or the ligament. Then apart from that, what happens that the portion of this clavipectoral fascia, it gets thickened along the lower border of the subclavius, and as I said, it extends from the coracoid process to the first costochondral junction, and there forms an ligament. That ligament we call it as the costocoracoid ligament. Now, so what I wanted to say that in the pectoral region, you will be getting this pectoralis major muscle, you have this pectoralis minor muscle, then you have this subclavius, and then you have the serratus anterior. These four muscles are there, and apart from that, we have the clavipectoral fascia. So the one of the important thing about the clavipectoral fascia, which is very commonly asked, that what are the structure which pierces this clavipectoral fascia, right? So just now we have discussed This is all about the pectoral region. Now we will see over here about the breast. Now when we see over here this mammary gland or the breast, this breast is a, you can say, the modified apocrine sweat gland, which is rudimentary in case of the male, and it is fully functional in case of the female. That is basically after the puberty, and it produces the milk to feed the babies, you can say. So when we talk about this, the location of this breast, it lies basically in the superficial fascia, and the two-third of the breast, you can say, basically, which is present in the superficial fascia, or because this superficial fascia, it is covering this pectoralis major muscle, it is also called as the pectoral fascia. So the two-third of the breast, I said that it lies in the pectoral fascia, which is on the pectoralis major muscle. Now, one-third of the breast, when we see, it lies in the superficial fascia lying towards the serratus anterior muscle. Now, when we see the shape of this breast, right, it is hemispherical in shape, and it extends, when you say the extension of this breast, right, uh, it is having the circular base, which extends from second to sixth rib vertically, and from lateral border of the sternum to the mid axillary line, you say, the horizontally. We'll see in the diagram over here in the next. You can see over here, this is the superficial fascia, right, covering the pectoral region, and over here you have this breast. Now, when we see the shape of this breast, it is hemispherical in shape, and when we see this extent of the breast in the diagram, you can see over here that vertical extension, it extends from second rib to the sixth rib, whereas the horizontally, when we see, it extends from the lateral border of the sternum to the mid axillary line. So this is all about the extension of the breast. Now, if we see over here in the next diagram, this is about the axillary tail of Spence. So what is the question arises, what do you mean by the axillary tail of Spence or the tail of Spence? So it is a tail-like projection, you can see in this diagram, which extends from the upper and the outer quadrant of the breast. The breast has been divided into the four quadrant, so it extends from this outer and the upper quadrant of the breast. So this tail extends from the outer and the upper quadrant of the breast, and it enters into the axilla. You can appreciate in this diagram through an opening in the axillary fascia, and that opening we call it as the foramen of Langer, and it is this is called as the axillary tail of Spence, and it is the frequent site of carcinoma of breast, you can say. Now we will see that what are the different quadrants of the breast. In this diagram, you can see that it is divided into the four quadrants. Over here in this diagram, you can see this is the supralateral quadrant, whereas over here you have this supromedial quadrant. Apart from that, we have this infralateral or the inferior lateral quadrant, and similarly we have the inferior medial quadrant. So there are basically, I said that the breast is classified, divided into the four quadrants. One is the supralateral quadrant, another is the supromedial, then have the infralateral and the inframedial quadrants. Now, if you see the relations of the breast over here, you can see that this base of the gland, if you see, it rests upon the following structures, and if you see over here, the spectralis major will be present in the medial two-thirds, right? You can see in this diagram, these are the structures. One is the pectoralis major, like the major portion, if you see over here, that is the medial two-third, you have this pectoralis major, whereas the one-third, you can say this portion, the lateral one-third, you have this serratus anterior, right? Apart from that, you have the external oblique aponeurosis. So in the medial two-third, we have the basically the pectoralis major is related, whereas in the lateral one-third, we have the serratus anterior, and inferiorly you can appreciate over here is the external oblique muscle of the abdomen. So these are the relations. These, if you see over here, these structures collectively will be called as the mammary bed. Now, just posterior to this breast, if you can appreciate, this we call as the retromammary space. So this retromammary space, which is filled with the connective tissue and the fat. And because of this, if you see, because connective tissues are there in the retromammary space. Due to these tissue deep to the breast you can say that is freely movable. So just because of this retromammary space which is filled with the connective tissue, and because of the presence of this connective tissue, we say this breast is freely movable. Now we'll see over here this the structure of the breast. The mammary gland, it consists of the following three components, you can say. One is the skin, another we have the stroma, and the third one, that is the parenchyma or the glandular tissue, or we say the mammary gland proper. So when we see over here the skin, this skin covers the mammary gland and it will present the nipple you can see over here, and then we have towards the lateral aspect of the nipple you can appreciate is the areola. So nipple, when we see, it is a conical projection, right? If we see over here, this is the conical projection which is present at the fourth intercostal space. Now when we see over here in the nipple, you will be getting this 15 to 20 lactiferous ducts which are open in at the summit of the nipple, you can say. So it has smooth muscles in it which can make it flat, or you can say that it makes the stand out. So it is richly innervated by the sensory nerves, and because of that you can say that it is sensitive for the tactile stimulation, and it becomes erect during this you say the sexual arousal. So this is all about this nipple. Now we'll see the areola over here. You can see just towards the lateral aspect of this nipple, you can appreciate over here is the areola. Now question arises, what is areola? It is the pigmented circular area of the skin which is present around the nipple, and this areola will have many sebaceous glands, and it will have the secretion, the oily secretion from them will be what is the function of this oily secretion? Because it will help in the lubrication of the nipple and areola, and apart from that it also helps in the, or you say it helps in the prevention of the drying or the cracking of the nipple. So their number and size becomes increased during the pregnancy, and when during this pregnancy, when the number or the size when it gets increased, that condition then we will say it is called as the Montgomery tubercles of pregnancy. So what I said, that during pregnancy the number and size will increase, and when the number and size will increase, these will be called as the Montgomery tubercles of the pregnancy. So these are nothing but the enlarged sebaceous glands which will appear like small nodules you can see over here in this diagram. Now the next, that is the stroma. If we see over here, we have this fibrous tissue. Now this have the fibrous tissue will form the suspensory ligament of the Cooper. In this diagram you can appreciate over here, these are the fibrous stroma, these are the suspensory ligament of the Cooper, right? Now these stroma, what happens, that these stroma provides the support to the structures of the breast, and these stroma includes the fibrous tissue over here you can appreciate, right? And these fibrous tissue condenses to form the septa, and that is called as the suspensory ligament of the Cooper. And when you see over here, these are radially arranged in the breast, and these are responsible for the protruded structure of the breast, you can say. And as the age advances, what happens, that the ligaments becomes atrophied, and it leads to the pendulous shape of the breast. So this is all about. Now when we see over here, what happens, that you can appreciate in this the pectoral pad you can say, or the fat pad you can say. So this forms the bulk of the breast, and it is distributed all over the breast, you can see in this diagram beneath the nipple or areola, everywhere you will find. So what I wanted to say, that the parenchyma of the breast is compound tubule alveolar gland, and it helps in the it secretes the milk, you can say, and it is divided into 15 to 20 lobes which are arranged in the radial fashion like the spokes of the wheel, you can say, right? And it will have ducts which converge towards the nipple. You can see over here in this diagram, these ducts converge towards the nipple and it opens into its submit. Before over here in this next diagram, you can appreciate this. You can appreciate over here that this is the nipple over here. These are the fatty tissue. These are the alveoli. Right over here, you can appreciate these are the lactiferous ducts which opens at the nipple. Now, when we see over here, the different age changes of the, you can say the breast structural differentiation you can see over here, which varies with the age and apart from not only age during the pregnancy and the lactation, from birth to pre-pubertal presence, you can say the lactiferous ducts will be there without alveoli. At puberty, the ducts will go further undergo branching over here. You can see this over here, the structural differentiation of the mammary gland. This was early childhood, that is between 1 to 10 years of the old. Over here, this you can see during the puberty, and this you can see over here during the pregnancy and the lactation period. So these are the structural differentiation of the breast you can appreciate. Now, if you see over here, this age changes of the breast, you can see this is the during the birth over here, you can appreciate. This is the during the puberty. You can see because of the help with the help of the estrogens, there will be the elongation or the bifurcation. There will be further branching will be there. There will be the side branching during the adulthood, and alveologenesis and the lactogenic differentiation will be there. So these are the different age, and accordingly there will be changes of the mammary gland. Now we will see about the arterial supply of the breast. Now when we see over here, this is the subclavian artery. From this subclavian artery, we have this internal thoracic artery. So when we talk about this blood supply of the breast, it is highly vascular, and basically we have this internal thoracic artery, which is a branch from the subclavian artery that will be supplying this breast. Apart from that, we have the lateral thoracic artery, which is a branch from the second part of the axillary artery, which comes over here. You can appreciate this is the lateral thoracic artery. Apart from that, we have this thoracoacromial artery, which gives the pectoral branch. So the pectoral branch of the thoracoacromial artery will also supply the breast. And apart from that, the superior thoracic artery will be there that will be supplying. So if you see over here, this is the superior thoracic artery, which is a branch from the first part of the axillary artery. We have this thoracoacromial artery, which is a branch from the second part of the axillary artery. And again, we have the one branch from the second part of the axillary artery, that is the lateral thoracic artery. So these are the various branches of the subclavian artery and the axillary artery, which will be supplying the breast. Apart from that, there will be the lateral branches of the posterior intercostal arteries that will also supply the breast. So I repeat, I said this, the breast will be supplied by the internal thoracic artery. Now this internal thoracic artery will give some of the perforating branches which you can over appreciate, right? So it gets its blood supply from the internal thoracic artery. We have this superior thoracic artery, the lateral thoracic artery, and then we have the pectoral branch from the thoracoacromial artery. So these are the various branches of the axillary and the you say the subclavian artery that will be supplying the breast. Now, when we see this venous drainage of the breast, the veins will be following the corresponding arteries, you say. So what will happen that first they converge towards the base of the nipple. Over here, you can appreciate, right? So what happens that first they will converge towards the base of the nipple, where they form a circle. That is the, you say, over here you can appreciate in this diagram, they form a venous circle, right? From where what will happen that the veins will run in the superficial and the deep set. Over here you can appreciate. So it forms two sets. One is the superficial and another will be the deep set. Now what will happen that the superficial veins will drain into the internal thoracic vein, which you can appreciate over here in this diagram, right? Then apart from that, what will happen that this internal thoracic vein over here, you can see these are the superficial veins which will drain into the internal thoracic vein. The deep veins what will happen, that it will drain into the axillary and the posterior intercostal vein. So I said that it will form the superficial set and the deep set. The superficial set, I said that it will drain into the internal thoracic vein. Over here, uh, the point to be remembered is that the posterior intercostal veins, what will happen, that it will communicate, this posterior intercostal vein will communicate this with the vertebral venous plexus, which in turn will communicate with the intracranial veins, right? So that's how this carcinoma gets spreads. So this is one of the very important point you should remember, that this posterior intercostal veins communicate with the vertebral venous plexus, which further will communicate with the intracranial veins. Now, we'll see over here the lymphatic drainage of the breast. Now, why this lymphatic drainage of the breast is important? Because the carcinoma of the breast is quite common in the breast, right? And for the surgeons, it is very important to know that how this lymphatic drainage is there for the surgeons, you can say. So it spreads mostly through the lymphatics. We call it as the sentinel lymph nodes. So we must know the lymphatic drainage of the breast. Now, if you can see over here, as you can see this lateral quadrant over here, right? We have this anterior axillary lymph nodes. You can appreciate in this diagram, we have this anterior group of the lymph nodes. Over here, we have the posterior group of lymph nodes. In this diagram, you can appreciate this is the central group of lymph nodes. Over here, we have the lateral group of lymph nodes. Now, what will happen, that from the lateral quadrants, the lymphatic drainage will be towards the anterior axillary or the pectoral nodes, whereas when you see this, the medial quadrants, there will be drainage towards the internal thoracic group, you can say, or you say the internal mammary nodes. Through this over here in this diagram, you can see this parasternal nodes, right? So towards this lateral quadrant, you can appreciate it goes towards this anterior group of the axillary nodes. Now, what will happen, that there will be the few lymph vessels which will drain into the posterior intercostal nodes. Now, from the inferior quadrant, you can, this side, if you see over here, some of the will drain into the abdominal lymph nodes. Over here, you can see in this diagram. So I said from this inferior quadrants, there may be some part will be draining into the abdominal lymph nodes, or you can appreciate over here the subdiaphragmatic lymph plexus. So what will happen, that there will be some lymphatic vessels which will communicate with the lymphatic vessels of the opposite side. Now, in the next diagram, we'll see over here, it forms the superficial lymphatics over here and the deep lymphatics. So this lymphatic drainage, it is divided into the superficial and the deep lymphatics. Now, what will happen, that the superficial lymphatics will drain the overlying skin, excluding the nipple and areola, whereas the deep lymphatics will drain the parenchyma of the mammary gland, including the nipple and areola. Now, when you see this superficial lymphatics over here, the superficial lymphatics will pass radially to the surrounding lymph nodes, that is the axillary or internal mammary, or you say the supraclavicular and cephalic lymph nodes. Whereas when you see this deep lymphatics, right, the deep lymphatics will drain the parenchyma of the breast, and these will also drain the nipple and the areola. What will happen, there will be a plexus of lymph vessels which will be deep to the areola, and that will be called as the subareolar plexus of Sappi. Now, when we see this subareolar plexus of Sappi, right, the most of the lymph from the breast drain into the anterior axillary lymph nodes. Over here, you can see this is the anterior axillary lymph node. So most of the breast will drain into the anterior axillary lymph nodes. Now, when we see, that is the 75% of the lymph will be draining into the axillary lymph nodes, whereas the 20% of the lymph will be draining into the internal mammary nodes. And apart from that, the 5% will be draining into the posterior intercostal nodes. Now, among these, if you see, among the axillary lymph nodes, if we see, the lymphatics end mostly, you say, in the anterior group of, or the anterior axillary, posterior, or you say the apical group of lymph nodes. Now, what will happen, from this anterior and the posterior group, it will pass towards the central lymph nodes, right? So over here in this diagram, you can appreciate over here. So it will pass to the central group of lymph nodes. And apart from that, you can appreciate over here, we have the lateral nodes. So basically from this anterior and the posterior, it will pass to the central and the lateral groups of the lymph nodes, and through them, it will go to the apical lymph nodes. So over here, in this diagram, you can appreciate over here, this is the apical lymph nodes. Finally, what will happen, that it will reaches to the supraclavicular lymph nodes. You can see in this diagram. So I repeat, what happens, that from here, right, if you can see, I said that 75% it drains into the anterior axillary lymph nodes. What will happen, it will go towards this anterior nodes and the posterior nodes. Through this anterior and posterior nodes, it will go to the central and the lateral group of lymph nodes. From there, what will happen, it will go to the supraclavicular nodes, and then finally it drains into the apical lymph nodes. Now what will happen, that this internal mammary nodes, if you can see over here, it drains the lymph not only from the inner half of the breast, but from the outer half as well. Now what will happen, that lymphatics from the deep surface of the breast through this pectoralis major muscle, what will happen, that, and apart from this clavipectoral fascia, it will reach to the apical lymph nodes, right? And it will also go into the internal mammary nodes. So this is from there, what will happen, that the lymphatics from the lower and the inner quadrants, as I discussed, that it will go towards the abdominal cavity via this subdiaphragmatic lymph plexuses, right? So this is all about the lymphatic drainage. But you should know the clinical classification is different, and that is important. So when we see over here in this diagram, that the surgical classification of the lymph nodes, when we see, it is divided into three levels: level 1, level 2, and the level 3. Now if you see over here, this is the level 1. So the level 1 group of lymph nodes will be present below the lower edge of the pectoralis minor muscle. So this is the landmark over here, and accordingly the classification has been done on the landmark is the pectoralis minor. So below the lower edge of the pectoralis minor, the level 1 group of lymph nodes is there, whereas when you see the level 2, that will be present underneath, or you have this posterior to the pectoralis minor muscle, whereas when you see this level 3 will be above the or towards the medial aspect of the pectoralis minor muscle. So I said three levels are there: level 1, level 2, and level 3. Level 1, I said, that is present below or the lower the edge of the pectoralis minor. You can appreciate over here. I said level 2 will be present either behind this pectoralis minor, or in front of the pectoralis minor, because when you see this rotor's lymph node, or you say the interpectoral lymph nodes, that is present between the two pectoralis muscles, that is between the pectoralis major muscle and the pectoralis minor. So that is rotor's lymph node or interpectoral group of lymph node. So that comes under the level 2. I said level 3 will be present above or the medial to the pectoralis minor muscle, that is the level 3, you can appreciate over here. So this is the surgical classification of the lymph nodes. Now, when we see this innervation, nerve supply, if you see over here in this diagram, you can appreciate, basically we have this anterior and the lateral cutaneous branches will be there from the 4th, 5th, and the 6th intercostal nerves that will be supplying this area. So what will happen, that through this the 4th, 5th, and the 6th intercostal nerves, it will supply the sympathetic fibers, right? So I repeat, that the nerves are derived from the anterior and the lateral cutaneous branches from 4th, 5th, and the 6th intercostal nerves. When we talk about, these are the sympathetic fibers. When we talk about the somatic fibers supply the overlying skin over here. So you can see this cutaneous innervation. We have the supraclavicular nerves. The supraclavicular nerves, it is further divided into three. We have the medial supraclavicular nerves, we have intermediate, and we have the lateral supraclavicular nerves that will be supplying this pectoral region. The skin, the cutaneous innervation will be there. right? So these are the lateral supraclavicular nerves you can appreciate. Over here, you have this medial, intermediate supraclavicular nerves, and towards the medially, you have the medial supraclavicular nerves. Now, this is all about the innervation. Now coming to the development. When we see this development of the breast, in this diagram, you can appreciate this breast develops from the ectodermal thickening, right? What will happen that it forms an ectodermal thickening, which is called the milk ridge or the mammary ridge, we say, right? Or otherwise, it is also called as line of sludge. This line you can see which extends from this axilla to the groin region. I said this breast develops from the an ectodermal thickening, which is called as the this milk line or the mammary ridge, or we say the line of sludge. So this ridge extends from axilla to the groin, and when we see this line, it appears during the 4th week of intrauterine life. But what happens that it disappears over most of its extent, and only in the pectoral region it will persist. Now what will happen that this gland is ectodermal in origin, whereas when you talk about the stroma, that will be the mesodermal in origin. Now the persisting part, if you can see in this diagram over here, the persisting part of the mammary ridge is there, mammary ridge is converted into a mammillary bud. Now what will happen, thus, in this diagram, you can see over here, this is the primary bud. Over here, further, there will be development, and there will be secondary buds that will be in 15 to 20 in numbers, and that will grow down from the floor of the pit. Now, what will happen that these buds will further divide and will subdivide to form the lobes of the gland. Now, the entire system, what will happen is first, initially, it is solid, but what will happen that later on it gets canalized, right? And at birth, or you can say later, the nipple is everted at the site of the original pit. So the growth of these mammary glands at puberty, if you say, it is caused by the estrogens. Whereas apart from the estrogens, you say there will be the development of the secretory alveoli, and which is stimulated by the another hormone we call it as the progesterone, and there will be another hormone we call it as the prolactin, and this prolactin hormone uh, which will be from the hypophysis cerebri. So these secretory alveoli will be stimulated by the progesterone and the prolactin. Now there are some certain birth defect means anomalies also, and these anomalies, if you see over here, that in the diagram you can see there will be that may be because of the birth defect, or it may be due to the cancer. Apart from that, there are ectopic nipple. We say it as the polythelia. When there is a additional nipples along the milk line, in this diagram you can appreciate over here, that condition we call as the polythelia. Now, when there is a supernumerary nipples, we call it as the hyperthelia over here. Then there will be condition whenever there is a agenesis or the absence of this breast, we call it as the amastia, or when it is rudimentary, right, it is called as the micromastia. So these are the different birth defects or the congenital anomalies: inverted nipple, ectopic nipple like polythelia, right, hyperthelia, amastia, and the micromastia. Now when we see over here in this clinical condition, you can see over here, this happens because of the infection of the breast tissue due to the cracked nipples, and this usually happens during the pregnancy. And whenever there is an infection of the breast, that condition we call as the mastitis, right? Now when we over here, when there is a development of the breast in case of the male, right, when the size is increased, that clinical condition we call as the gynecomastia, right? And this gynecomastia usually occurs in the Klinefelter's syndrome. Now there are the different diseases of the breast, and these diseases of the these may be of the different regions, the etiology are unknown, and the influencing factors may be basically the hormones, the sex hormones are there, and it may be because of the hereditary regions, that is the genetic regions. Now, when we see this clinical condition, we call it as the fibroadenoma. Now, this is very common. You can say the most common benign breast tumor, that is called as the fibroadenoma. In this condition, this breast will be free, mobility will be there, and the most common malignant tumor among women, if you see over here, that will be among 1/8 of the women which will develop this malignant tumor in the breast, right? And the only thing, if you see over here in this malignant tumor, there will be the early diagnosis, and the proper treatment will be the cure of the disease. We say the breast self-examination, right? That is very important for the early diagnosis. So if it is diagnosed early, right, and the proper treatment is given, it can be cured. Now, when we see over here in this carcinoma of the breast, there will be the different stages. Initially, you will look for the lump. If there is a lump, when you palpate, self-examination, when you do, when you feel there is a lump in the breast, and apart from that, there will be the pulled in the nipple, there will be dimpling or the discharge from the nipple if there is, right, the dripping, or there is a redness or the rash, the skin changes is there. These are the different signs of the carcinoma of the breast, right? So to diagnose this carcinoma of the breast, I said these are the signs of the breast. That is the presence of the painless hard lump, right? What will happen? The breast will becomes the fixed and immobile due to the infiltration of the suspensory ligament of the Cooper. Then another sign, that is the retraction of the skin due to infiltration of suspensory ligaments. Then apart from that, retraction of the nipple will be there due to infiltration and the fibrosis of the lactiferous ducts. Apart from that, the pseudo-orange, that is the orange skin appearance, will be there, and that is due to the obstruction of the superficial lymphatics. Apart from that, there will be discharge. If there is a discharge and the female is not pregnant, that also may be the sign of the breast carcinoma. And apart from that, there will be enlarged axillary lymph nodes. So these are the various signs of the breast carcinoma. Now, what do you mean by the orange? This is the, you can see in the diagram, this is the edema of the skin, and the appearance will be the orange skin, right? And this happens due to the blocked cutaneous lymphatics will be there, right? Now, the diagnosis, if you see the clinical examination, the patient may go for the various investigation like mammogram. There are facilities MRI, that is the magnetic resonance imaging. Apart from that, if you see over here, the fine needle aspiration cytology, that is the FNAC, these are the investigation. Apart from that, we have this treatment, that is the surgery, radiotherapy, chemotherapy, right? So these are the treatments available in case of the carcinoma of the breast. This is the procedure you can see over here, that is the fine needle aspiration cytology. So this is, through this what will happen, that cells are aspirated from the breast and analyzed under the microscope, right? So this is the, apart from that, you have this mammogram over here. You can see this is the, in case of the breast cancer, you can go for the MRI mammogram. Now, what happens? Metastasis of the breast cancer. So in case of the metastasis of the, how it spreads, as I said, that the posterior intercostal veins, right, it communicates with the vertebral venous plexus, and in turn this vertebral venous plexus, it communicate with to the intracranial dural venous plexus of the brain, right? So this is how this breast cancer spreads. Now there is a clinical condition, Krukenberg's tumors. What will happen, that there will be the deposition of the breast cancer cells on ovary by the transcoelomic migration, right? So this is all about. Then the surgical removal, there is a procedure we call it as the mastectomy. What will happen in that the breast is removed? So surgical removal of the breast, that procedure we call as the mastectomy. It may be the modified radical mastectomy. So removal of the axillary lymph nodes and the preservation of the pectoral muscles. Now, what will happen, that there are during this surgical means treatment, you can say there are the requirement when we have to remove the breast, and that procedure, the surgical removal of the breast, that procedure we call as the mastectomy. During that procedure, there are the different types of incisions are there. Over here, you can see in this diagram, this is the curvilinear incision. Over here, you can see this is the during around this areola, you say over here, we call it as the, when we give incision around this areola, we call it as the circumareolar incision. When you can see this is the radial incision, which is often preferred when we need to drain over here. So to avoid injury to the ducts and all, we prefer to give this radial incision. Over here, if you see another incision, we call it below this mammary gland, we call it as the inframammary incision. So there are the different types of incision which we prefer or during this organ which produces milk, right, for the young offsprings, you can say, and which rising incidence of the breast carcinoma is there. Because of that, you say the anatomy of the breast is very important and it has become vital for the diagnosis and the treatment, right? So just to summarize, in the I said that in the pectoral region, you have the different muscles. That is the pectoralis major muscle you will be getting, the pectoralis minor you will be getting, right? And then you have, and then apart from that, you have the serratus anterior muscle, right? The pectoralis major muscle, I said, it will be, it gets its origin, the most important thing you should remember about this pectoralis major, that is the bilaminar insertion, right? It forms the two lamina, the anterior lamina and the posterior lamina, and it gets inserted over the lateral lip of the intertubercle sulcus. It arises from this clavicular head, it arises from this sternocostal head, and it arises from the aponeurotic head. And I said it inserts on the lateral lip of the intertubercle sulcus, right? I said that anterior lamina will be found by this clavicular head, which comes from the above, whereas when you see this aponeurotic head, it forms the posterior lamina, and the base of the U-shaped, you say it is formed by the sternocostal head. We discussed that it is supplied by the lateral pectoral nerve and the medial pectoral nerve. Both the muscles, either you talk about the lateral pectoral nerve or you talk about by this pectoralis major or the pectoralis minor, both are supplied by the lateral and the medial pectoral nerve. This pectoralis minor, I said, it arises from third, fourth, and fifth ribs and the costal cartilages. It inserts on the where that I said the coracoid process, right? That is on the medial border and the upper surface. Now I said both the muscles are supplied by the same nerves, right? It stabilizes, it helps in the uh, stabilization of the scapula, whereas the pectoralis major, I said, it helps in the adduction or the medial rotation of this upper limb, the shoulder joint, right? Then I said the subclavius is there, which is supplied by nerve to subclavius. It arises from this first rib, or you say the costocardialis are there. It inserts on the inferior surface of the, what we say, that is the subclavian group, floor of the subclavian group, right? It is also, it's supplied by nerve to subclavius, which will be, the root value will be C5 and C6, right? Then I said the serratus anterior, very important muscle because clinically it is significant. I said this, when there is an injury to this nerve to serratus anterior, right, it will lead to the paralysis of the serratus anterior muscle, and that will lead to the winging of the scapula or the winged scapula, right? Then I said that these are the muscle. Apart from that, the Poland syndrome, clinically I said that in case of the Poland syndrome, there will be the absence of this partial or the complete absence of the pectoralis major muscle, right? So this is all about this, you say, this breast, right? Now, uh, regarding this breast, if you see, I said that breast is an important asset. You say it is rudimentary in case of the male, whereas basically it is present in the females, right? And it is an accessory reproductive organ. It is very important because of the clinical significance, because the uh, most of the females, we say that they suffer nowadays from this breast carcinoma. So I said that we should know the anatomy of the breast, because the lymphatic drainage of the breast is very important. In the lymphatic drainage of the breast, I said that surgical classification is there, which has been divided into level 1, level 2, and level 3, right? So that is on the basis of the pectoralis minor, right? So this is all about. Any questions are there, that will be most welcome.
Thank you very much, Dr. Ravi. It's a very detailed, session that you have conducted for our students. There are a few questions that we have got so far, sir. So I'll just go one by one for all these questions. One is, what is dimpling in breast during breast cancer? Dr. Ravi, am I audible to you, sir? I request you to please be patient. Dr. Ravi is going to answer all these questions very soon. Dr. Ravi, am I audible to you, sir?
Am I audible, sir?
Yes, sir, you are audible. Sir, there are a few questions that we have received in our Q&A sessions. So I'm
Yes,
just telling you these questions, like, what is dimpling in breast during breast cancer?
sir. Dimpling of the breast cancer, it is a sign, right? It is a sign of the cancer, one of the sign, you can say. Uh, uh, Basically, there is a sign that is, I said that pure orange. That is what will happen. The skin will become orange, right? So that is called as the pure orange, and that is one of the sign of the breast carcinoma. In that, you will find that there will be dimpling of the breast. There will be formation of the dimple, and because of that, I said the skin becomes the orange, and that sign we called as the pure orange. Am I okay,
Okay,
sir?
sure, sir, sure. Sir, what is the frequent site of carcinoma of breast?
So upper outer quadrant is the frequent site of the most common site of the this you say that is the breast carcinoma.
Okay, they also are saying, what is Krukenberg syndrome?
This Krukenberg tumor or the syndrome, what we say, it is a sir, malignancy, that is the metastatic malignancy, you can say. What will happen that in that there is a malignancy of the ovary, right? And in that only you will find that there will be a tumor formation of the tumor, right? And that tumor we call as the Kruken tumor. And that is in that, what will happen that there will be formation of the signet ring appearance, that is the adenocarcinoma, that they will study in the pathology. When they will go to the pathology, that time they will study. So it is a what I wanted to say, that it is a it is not a benign malignancy, but it is a metastatic malignancy of the ovary,
Great,
and
sir.
that the sign will appear in the breast, you can say, right?
Okay,
So this
okay,
this,
okay,
this is of the metastatic nature, we can say.
okay, sir. So can you
Uh,
please tell us the histology of the breast?
Microanatomy, I've already discussed over here, right? So when we see over here this microanatomy of the breast, right, there is the formation of the parenchyma. I said we have, if we see over here, there that forms the ducts. It forms the at the summit of the ducts. You say it forms the nipple. So when we see, there will be the different. It is present basically. You say the fourth intercostal space. So these, when we see over here, there is a formation of the stroma will be there, right? Now these stroma will provide the supporting structures of the breast, and that will include the fibrous tissue and the fat. Now what will happen that when you see this fibrous tissue, it condenses and forms the septa, right? Now what will happen that these septa, that is called as the suspensory ligament of the Cooper, right? These will arrange radially, and this will be the this will responsible for the you say the structure of the breast basically. So what will happen that as the age will advance, what will happen that these ligaments will become atrophied, right? So I said that because of that only the shape of the breast changes, means that becomes the pendulous, right? Apart from that, I discussed about the parenchyma, right? So parenchyma of the breast, you say, is the compound tubule alveolar gland, and that secretes the milk, right? And these parenchyma, what will happen that it will divide it into different lobes. Basically, it is divided into 15 to 20 lobes, and as I said that it is arranged in the radial fashion, right? Like the spokes of a wheel, what you have seen in the wheels. In the wheels, you find the spokes. So accordingly, these are arranged in the uh, wheel, like means I said these are arranged as spokes in the wheel, right? That is the 15 to 20 lobes which are arranged radially, right? Now what will happen that these will come towards, means converge and forms the nipple. And then I said that each lobe is divided further into these lobules will contain the cluster of acini. Now what will happen that each lobe will be drained by some of the, means we say the lactiferous duct. Now what will happen that these lactiferous ducts will uh, converge towards the nipple, as I said. And what will happen that before they open, means it opens into the summit, these ducts will forms the a region we call as the extended region, we say that region we call as the lactiferous sinus. So these lactiferous sinuses uh, will be the temporary storage for the milk, especially during the lactation you say, right? So this is all about the structure or of the breast, you can say.
Okay, sir. There's another question: is carcinoma of breast are common in nulliparous persons compared to multiparous? Is in transgenders,
Yes, you
are there any studies done to show relation of CA, breast, and hormonal imbalance?
pardon. Can you repeat the question?
So repeat the question is: carcinoma of breast are common in nulliparous persons compared to multiparous. In transgenders, are these any studies done to show relation of carcinoma breast and hormonal imbalance?
See, nulliparous women, if you see, it is between approximately 35% are there cases, right? So basically, if you see over here, uh, the post-menopausal breast cancers are there, right? In comparison to the nulliparous. So if we say that the nulliparous people are more prone to the cancer, so as per the data, as per as I know, it is approximately 30 to 35% in range. We can say that they are more prone to the cancer. That is the data. I cannot say about this transgenders, right? So about that. So this is all about transgender. I'll have to check. I can get back to you later. But that is what I can say, that among the nulliparous women, the risk of this cancer, you say, basically during this post 35% or so.
Okay, great. Another question is, sir, uh, which part of axillary lymph nodes pass clavipectoral fascia and why?
Lateral, if you see over here, so I've already discussed that what are the structure which passes through this. You say this clear pectoral fascia. There are the four structures I said, I discussed, isn't it? If you remember. So what are
Yes,
those?
yes.
So if they remember, just now I said that it is the lateral pectoral nerve, right? And then apart from that, I said this thoracoacromial artery is there, right? And in the thoracoacromial artery, if you say apart from that deltopectoral nodes, I said, right? So these are the structures which will be piercing the scleropectoral fascia. I repeat, I said that we have this thoracoacromial artery or the vessels you say, then the deltopectoral lymph nodes will be there, that will be passing through that. Lateral pectoral nerve will be there, and then apart from that, one vein is also there, that we call it as the cephalic vein. So these are the structures which passes through this cleropectoral fascia. Anything
Okay.
else?
Yes, sir. Sir, one question. Another is what is Krukenberg syndrome?
Krukenberg tumor, just now I said, that is the metastasis, means malignant condition is there of the ovary, and in that only this Krukenberg tumor is one of the sign, that is the malignant tumor, right? It
Okay.
is one of the sign of the metastasis, means when there is a cancer of the ovary that will appear in the breast.
Okay. They're saying they're trying to. Can you please explain the difference between polythelia and supernumerary nipples?
I said polythelia means when there is a extra nipple, only one nipple is there. Am I visible or not?
Yes, sir. Sir, you are audible, sir. You are audible. Sir, can you showcase your screen?
I'm not visible screen.
Not right now. It's not visible. Just it has just gone away.
Okay, so just hold on.
Yes. Yes, sir. Please go ahead.
What happens? Hello.
Yes, sir. We can hear you, sir. You can. It is presenting now.
Uh, uh, yes. Hello. Am I audible?
Yes, sir. You are audible, sir. You are audible.
Tell me please.
So our next question is, what is mammary pit?
Pit, there is a depression over here. The question I think somebody asked about the polythelia. So whenever there is a means more than one nipple, we call it as the polythelia, right? And supernumerary, when in the milk line only. Apart from that, there are extra nipples are there, that we call it as the supernumerary.
Okay. Another question is, sir, what is mammary pit?
Mammary pit, there is a depression, right?
Okay. Okay. And what is the tail of Splank means?
Tail of Spain's. I said when there is an extension of the breast over here, which goes towards this axilla. In the diagram, you can see over here. Uh, you can see over here. This is the extension of the breast, right? Tail-like projection. So which goes into the axilla, which extends towards the axilla, right? And passes through this one opening is there in the axilla, that is called as the foramen of Lange. So this extension of this breast towards the axilla is called as the tail of Spain's.
Okay, sir. Sir, since clavipectoral fascia is derived from prevertebral fascial, where do we find prevertebral fascia?
Pardon?
Since clavipectoral fascia
Uh-huh.
is derived from prevertebral fascial, where do we find prevertebral fascia?
Prevertebral fascia over here, you will not find. That is towards the vertebra in the neck. If you see, or it goes towards the means around the vertebra, you will be getting this prevertebral fascia.
Okay. Sir, what does mastectomy affect another secondary sexual character in the body?
No, it doesn't affect acid, because this is the secondary. Usually, it doesn't affect, because I said it is accessory reproductive organ.
Okay. What is polymastia?
Polymastia, when they have more than one means breast is there. That will be the yes. Poly
Okay.
means many. So that is the literal meaning of that.
Okay. Why do we remove breast rather than removal of mass in breast cancer?
So it depends on the condition in which stage it is there, right? Suppose it has not spread, much, and only a portion of that can be there. It because as I said, that it spreads through this axillary lymph nodes. So because of that only the clinicians decides that whether the mastectomy or part of the thing has to be removed or complete. So it depends on the condition, which condition or which stage it is there.
Sure, sir. Sir, the last two questions are: is Poland syndrome can be seen in females too?
Why not? I said that Poland syndrome, it is the partial or the complete absence of the pectoralis major muscle, right? So it is a developmental defect. It may be there. Why not?
Okay. So another last question is: what is axillary tail of splens?
I said axillary tail of spines just now. I explained,
Okay.
right?
Okay.
That is the projection of the breast towards the axilla.
Well, thank you so much. It's a very detailed discussion today. We had a lot of questions were there. I hope that we've been able to answer most all of them. And there are certain queries about that. The people want to be more, know more such or need more such webinars in the future on the anatomy subjects, like the way you taught. So I have told all the attendees that they keep on checking their emails because we'll be doing much more webinars in the coming future. And yes, they recommended that we should have it on the weekends. And another request is that we should have it by starting by 6 o'clock, as students will have more time to attend the sessions. We are also going to provide the recording of the webinars to all the attendees who have filled their feedback forms on the link that I have shared with the teams. Again, a very thankful note to our speaker, Dr. Ravi Satish Kumar Ravi, who has been taken his time out from the busy schedule and giving us a very informative and speech to all our first year students. With this, we conclude this session today. I'm thankful to all my attendees to attending our sessions. We'll be coming up with more such webinars in the future.
So thank you so much, Mr. Ravi, for organizing this webinar, right? I want that most of the students should attend, and whatever we can deliver, we should deliver, right? That is our agenda, that whatever we can, we should. And whoever has any, means if some students wish to uh, learn some specific topic, they can provide us, they can email us, and we'll try to take lecture on that specific topic, right? Today my health was not so good, but still we managed. Right? But if you need any specific topic to be taught, right, we will try to cover those topics. So you can email, and then we will accordingly arrange the classes.
Sure. Sir, I'm also giving my email ID to all the attendees. So if they want any particular topic, which we should cover, they can write to me directly.
Right. So thank you so much. I thanks all the participants also for attending this webinar. Right. Thank you so much.
Thank you so much, sir. Thank you so
I'll
much.
write the email ID DRKS Ravi. It is there in the PowerPoint also.
Sure, sir. Also, just to inform that we will be having around 16 more sessions, on the topics of the various topic of anatomy, which are very much useful for students, as well as also they have a very good relevance in terms of examination. That and their appearance of the question from these topics are very much likely to be in the examinations. So thank you so much. Be ready to be checking your email, for more notifications about these webinars in the future. Thank you so much,
I'm
Dr.
able
Ravi.
to send the message actually to
Sure.
them. Okay. Thank you so much.
Thank you, sir. Thank you so much.